Hi, everyone. We are getting started. Welcome to our first webinar in the PrEP financing series that we're going to host over the next few months. This one's focusing on PrEP health plan assessment tools and navigators. We are excited to launch this web series. We'll talk more about the next webinar sessions, but we are excited that you're here today. So stay tuned. To start with, we're going to have you complete a poll question. We're going to have a few of these throughout the webinar today, just to get a sense of who's in the room. You can complete the poll by just clicking on your screen for the options that might apply. As people complete the responses, just a couple of housekeeping items. We're going to keep everyone muted to make sure that we can all hear the speakers. And at the end, we'll have a question and answer session. We've allocated a lot of time to be able to have a robust discussion. So we're looking forward to that. If you have any questions, any clarifying questions in particular, or questions that you want to make sure we address at the end, you can put them in on the chat function, and we will forward those to the speakers. Great, so let's look at the results. So it looks like people have pretty varied experiences. That's great. Welcome, welcome. So for today, we have 3 presentations. We're delighted to have David Evans from Project Inform talk about the health plan assessment tool that Project Inform developed together with other agencies in California. And Cesar Segurola and Alisa Guido are going to talk about their efforts in Arizona. They also developed a health plan assessment tool, some guidance, and have started to do other research. So we're excited to have them here. ATECs are going to be crucial in these efforts. So it's great to see these kinds of innovative work. And then Todd Grove and Adam from the Colorado Department of Public Health and Environment are going to talk about their navigation practices and the innovations that they've been able to establish there. And it should be an exciting presentation. And once again, we're going to have a lot of time for discussion. So just as a brief context, the importance of the tools and navigation that we are talking about today is particularly important because for PrEP, we don't have a safety net to ensure access for vulnerable populations. So there's a critical gap in funding for PrEP. CDC has funded a series of new demonstration projects for PrEP, but these funds cannot be used to pay for the medication, laboratory testing, and clinical visits that are needed for the intervention. HRSA is restricted in serving HIV-positive individuals, so they cannot fund services for PrEP. Healthcare reform has enabled millions to access health coverage, but 19 states have not adopted Medicaid expansion yet, and people at risk in those jurisdictions, and many of these jurisdictions are high prevalence, have high prevalence rates And so for these vulnerable populations, access to health insurance is still a big barrier in relation to being able to access PrEP. And even for those with health insurance, high copayments and out-of-pocket maximums, deductibles make it hard for individuals to leverage PrEP. So again, CDC published an estimate that over 1.2 million individuals are indicated for PrEP, and yet the best kind of rough estimates that we have are put current uptake of PrEP at somewhere between 3 and 4%. So we have a long ways to go, and I think the tools and experiences that you're going to hear about today point to activities and tools that we can use without necessarily having specific funding for PrEP. We've found a few models and funding mechanisms that have been proven to be very successful. Community health centers have led the way. They serve as a gateway into primary care for individuals at high risk of acquiring HIV, and they've been able to gain access to more frequent STD testing, HIV testing, adherence counseling, and they also have been able to access the medication at a discounted price. A couple of health departments have been able to set up drug purchasing and distribution mechanisms and even provide assistance with insurance premiums using the infrastructure and expertise of the Ryan White and state funding to purchase the drug. But they haven't been able to access the same price discount. And local health department STD clinics also have played and are increasingly so playing a critical role reaching underserved populations, primarily those who don't have access to primary care for multiple reasons, and STD clinics have also been key in referring high-risk individuals to clinical providers. And of course, the community partners have been key throughout all of these different interventions. And I want to emphasize the insurance counseling and assistance has been key throughout all of these models. So I'm very excited to talk about and discuss this piece. We're going to hear today about the different cost elements that need to be taken into account to help someone kind of navigate a complex system of health plan coverage and gain access. And the tools that we're going to be hearing about today have great potential to minimize the cost of the intervention for an individual and at the same time expand access to it by leveraging health system payers and not just categorical funding for HIV prevention. So with that, I'm going to turn it over to David Evans, who is going to get us started. Take it away, David.
There we go. So I want to start off my my comments by first acknowledging my colleague, Ann Donnelly. Some of you may know of her or have heard of her. She's one of the most brilliant advocates and policy experts on healthcare expansion, and particularly Medicaid and now the exchange plans and the implementation, particularly HIV care, but for people living with HIV, but increasingly Hep C and PrEP. So she really is the person that sets the structure of what we do. And I've been working on PrEP issues for quite some time, and increasingly we are working together more and more. But I want to give her her fair due. There we go. So what I'm going to cover is the landscape of ACA rollout for people living with HIV during that first year. and particularly what we learned, we were an early Medicaid expander. We received a waiver to start a year early. And that was a really rocky road, and in doing that, we uncovered a whole lot of problems that would likely affect permanent Medicaid expansion and then the ability for uninsured individuals to purchase plans on the exchange. And we rolled that into some of the work that we've done since. In particular, and I'll mention this, we really found that the way that the Medicaid expansion and the plans were constructed, they hadn't really given enough thought to the fact that people living with HIV, many of them were being cared for and getting multiple kinds of services within a medical home model. And the thing that we fought hardest about was how to retain those medical homes and the access to those providers and the drugs that people needed. I'm going to talk a little bit about how we constructed our original plan choice guide and the formulary analysis and the lessons we've learned. What we did in year 2, which is where we expanded information on PrEP, some special considerations around PrEP with these kinds of tools, and some thoughts about the future. So the kind of landscape at the launch of the plan was that certified ACA navigators often knew nothing about HIV care and treatment. That shouldn't be a surprise because the numbers of people living with HIV really are a drop in the bucket compared with most other chronic conditions and the kinds of chronic conditions that people who were enrolling in the exchanges had, so heart disease, diabetes, and other kinds of things. And as I said, our situation was largely transferring people from one kind of care funding source and system to another, as opposed to enrolling people with no previous form of health care. And so as a consequence, we relied very heavily on our ADAP navigators, our case managers in the system, and that sort of thing in California. And that was an important resource to leverage. But unfortunately, those individuals and people living with HIV were often not aware that drug choice and tiering and cost sharing for labs and that sort of thing would be an issue. And that certainly comes up with PrEP as well. The other part of it is that the insurers themselves, they were used to employers and employer groups kind of shopping their plans, and they had tools in place to help those individuals do it. And those individuals, really knew what they were looking for. But they didn't have good tools for consumers. And so even us, at Project Inform, who had a good sense of what we were looking for, we really struggled to find the information we needed. It's better now in California. I don't know how it is in other states. I suspect you've run into the same thing, and maybe our other speakers can comment on that. So our proposed solution, one of them, was to write a guide that provided general information on the key elements of the ACA and the coverage options. That it also included a list of the key questions and concerns, so the kinds of questions that people should be asking themselves, a navigator, a provider, and each question was followed by our solution to those questions. And we really tried to include information for how people would want to analyze the plans and coverage in terms of things that they might not have thought of. So for instance, would all of the providers that they were currently seeing, not just their MD, primary care physician, but other specialists, mental health, substance use, would all of those providers be in the plan? And then we wanted to gather information on whether plans included all HIV drugs. They didn't. Including the fixed dose combinations. They didn't. And fixed dose combinations are basically when two drugs are combined into a single pill. Sometimes that's called a single tablet regimen, which is where all the drugs in a whole regimen are included. But some fixed dose combinations are not a whole regimen for people living with HIV. Truvada is one of those. It's just part of a whole regimen for people living with HIV. And we wanted to know what cost sharing would be and whether prior authorizations would be necessary. Some of the external players that were helpful in this process included experts on the statute itself, state ACA administrative and regulatory bodies. In California, it's called Covered California, state Medicaid staff, the plans themselves, healthcare providers, the State Office of AIDS, and the Ryan White administrators at the state, local, and county level. So lessons learned was that this was a lot of work, and we started too late in order to be able to get the work done on time. Our organization did all of the formulary analysis ourselves. We did partner for the piece on how to choose a plan. We have a lot of plans in our state. We're a huge state. And so in our case, it was really daunting. If you only have one plan or a few, it might be a little bit easier. One of the things we also realized after publishing that formulary analysis, based on information provided to us from the plans, we heard back from Covered California that ours was incorrect and that they had more up-to-date information. And we were sort of like, oh no, what are we going to do? So we thought, okay, well, let's take their information and let's go back to the plans. And what we found was even Covered California's information wasn't correct. And what we learned is that the plans are allowed by law to change their formularies. If they wanted to change their formulary every single day, 365 days of the year, they could. So that provides a lot of uncertainty into how things are covered. They can also introduce prior authorization and other controls pretty much at their whim. And so the bottom line is that, you know, this is a situation in flux. And so it makes it really hard to help people choose a plan that is going to serve them best. Another set of lessons learned were that there are lots of advocacy priorities that came out of this, including out-of-pocket limits, better rules and controls from the state coordinators in terms of the, for instance, so there was really confusing and limited information from the plans to help people make choices, and we advocated very strongly for the ACA coordinator in our state to force the plans to do more. Also, the pharmacy and therapeutics committees, these are the group of quote, experts that decide what the formularies look like. Pretty much across the board, they knew absolutely nothing about HIV treatment. And so without some form of external advocacy, the formularies made absolutely no sense. They've gotten better. So for our next iteration, it took a village, and these organizations and individuals in those organizations really made all the difference in our second year and helped us get the plan. I think it was better, a lot better, and we got it out really fast. So partnership is really helpful if you can build those partnerships. So just a few highlights about the plan. This one included Hep C and PrEP. We threaded throughout where the considerations for choosing a plan were the same for any disease. We didn't go to a lot of trouble to say that. But where there were specific issues to PrEP or Hep C, we did include those as call-out box. And we tried to make it easy for people to have a tool that they could bring to a navigator or a case manager or a PrEP clinic person or a navigator to get the information and have the information that they needed. So a checklist was done. In terms of the formulary analysis, the table, I just want to call your attention to the blue box. And basically, we also included information on prior authorization, not just whether the drug was covered in the tier, and any additional notes that we found from the plan persons. So, you know, if a drug, even if it wasn't on prior authorization, let's say it wasn't even on the formulary, how do you get the exception made, those kinds of things. And with PrEP, what we found is that I think last year, without exception, PrEP was not even stated on the formulary, so the use of Truvada as prevention wasn't there. I don't know if that will change. We've had a couple of circumstances in California where a plan made it very difficult for someone to get Truvada for PrEP. Advocacy efforts were successful in each of those cases that I'm aware of. So getting consistent information and PrEP-specific information on the plan guides, I think, might be important. And it seems like some of you are doing that already in your states. But people need more, particularly people seeking PrEP. So there have been a significant proportion of PrEP seekers, and this is, anecdotal information I get from clinics and STD clinics and navigators all over the country, that a lot of people seeking PrEP have no insurance. And so, they show up in June and they can't get a plan until October or November. So they're kind of stuck in the middle. Those without insurance often can't afford the gold and platinum plans with very low cost sharing. So that's an issue, particularly with the the medication assistance programs and the copay programs. People have a lot of problems navigating the process from start to finish, and some people gave up by the time they got to a PrEP navigator. And that the Gilead MAP and the copay programs, both from Gilead and the private foundations, are necessary for most people, and that they change regularly, sometimes for the good based on advocacy, but in the case of recently the Patient Access Network, PAN, for the bad, in that they stopped enrollment and probably will be discontinuing, although I hear rumors otherwise. The other tool that we realized people really needed was a simple flow chart that talked about how to get PrEP from start to finish. So checking your insurance plan, finding a provider who supports your decision, thinking about the medical visits, actually getting the prescription, what might stand in your way, picking up the prescription. So are there 30-day fill limits, those kinds of things, and then how to pay for the medication and other costs. So some of the suggestions for effectively guiding coverage choices, and these are things that we are thinking about doing for this next open enrollment period. And so if these feel helpful to you, that would be great. We hope to survey kind of informally or formally what prospective PrEP users know about medical insurance and coverage issues, as well as what they, we do a lot of surveys of awareness of PrEP as a prevention option, but there aren't a lot of surveys of HIV negative people at risk and what they know about obtaining health insurance and health care. To collect data from navigators on what some of the most common gaps in information and the challenges with getting covered might be. It's important for people not to forget that PrEP is not a protected prevention service. The U.S. Preventive Services Task Force, the CDC has applied for review. It looks like we might get it, but that's probably 2 years away. So the ACA plans must provide services for free to services recommended by the USPSTF. So we should look forward to that in the coming years. And this is one of the things that Edward mentioned, that we struggle with, and I know navigators struggle with, which is how do you weigh the value of a particular level of plan, bronze, silver, et cetera, and your premium versus your other needs and wants, and how you might use your health care. And sometimes helping people value that is really challenging. And it's 100 times more challenging in Medicaid in states that have not expanded Medicaid. So our considerations for next year to improve what we've done is to do a PrEP Navigator boot camp. We already do this for Ryan White in California, and we thought it might be helpful to do this before open enrollment this year. Possibly pulling our PrEP guide as a standalone guide and doing a heavy push to get it into the hands of people living with people at risk for HIV infection, and also the people that serve them, so prevention workers, testers, et cetera, navigators and providers in STD clinics, et cetera, people who have not been traditionally providing ongoing HIV care. We had good databases to getting them out to those individuals. What we haven't been able to do is really get these guides out to people who would be guiding people to PrEP, and so we'd like to do that. This year, possibly not publishing a separate formulary analysis. There are two reasons for this. One is that in California, the formularies have gotten better. They include most drugs. So far, we're forcing them to keep all the meds on the list and have the fewest prior authorizations. That's not true in every state. We know that. So this may be something that you might go one or the other way. So just some thanks to the people that were involved in this process, and again, Ann Donnelly in particular. So that's it.
Thank you, David. So as we transition to Cesar and Alyssa's presentation, we just have a couple of questions. The polls are open. A few people have, as everyone kind of finishes responding to the poll, a few people have already started to put in questions in the chat function. I just wanted to remind everyone that we'll come back to these at the end of the three presentations. I have just a couple of stragglers, and let's see what we have. So almost 40% of respondents have a tool that could be adapted for PrEP. That's pretty cool. I think this is something that's going to be useful in our conversation as well. We have two more questions. What kind of information would be most useful to insurance navigators? There were many different pieces to that David talked about. Which ones resonated with you the most?
And Edwin, it occurs to me that along with the slides, it might be really interesting to provide information on how the results of these polls that you're doing throughout the course, because I think people might value that information too.
Yeah, absolutely. We'll also have, we're hoping to compile suggestions about what other tools or resources NASTED could provide, and we will try to share those as well. so the visual map is the most popular. But I think we can see that all of these different pieces are critical in helping individuals navigate this complex process. And for our last poll before we get to Cesar and Melissa's presentation. David, as participants respond, what have been the most what's been the response like to the tools that you've published?
So far we hear that people have found it really helpful. I think like whenever you publish a tool, and I'm sure you know this from NASTAD or the other people that work at the state or county level, people get so much paper and so many emails that it's hard to figure out what thing is going to be most important for them to read and use. And so I think, if there have been any challenges, it's actually getting people to know that it exists and how it might help them. But when we are successful at that, we're hearing that it is very, that it's very helpful. And some of the comments we got, we included in the second year.
Thank you. The denial of insurance claims is something that we want to follow up with. So I think we'll have a box at the end of the webinar. If you indicated that there have been claims denied for PrEP, please include any comment in the chat box or at the end in the feedback responses. Thank you. And with that, we will hand it over to Cesar and Alyssa.
All right. Thank you to Edwin and NASTAD for the opportunity to present today into our health plan assessment tool. My name is Alyssa Guido. I'm the Program Director for the Arizona AIDS Education and Training Center. We are a local partner of the Pacific AIDS Education and Training Center region. For those of you who are not familiar with the AATCs, we are funded under the Ryan White Part F program. However, the tool that we're talking about today was part of a collaboration that we did with the Office of HIV Prevention at the Arizona Department of Health Services and was supported with CDC prevention funds. So last summer, the HIV Prevention Office approached the Arizona AATC to see how we could help support the state in their expansion of PrEP services throughout Arizona. So the tool that Cesar is going to talk about today is really just one component of a larger assessment that we did. And I think the last presentation was a really great 50,000-foot view of what's happening on PrEP. And our presentation is really getting into the nitty-gritty of what's happening here in Arizona and how Cesar is helping patients access and pay for PrEP. So if you could advance the slide, Cesar. I just wanted to point out before I turn it over to Cesar that all of our reports that we did as part of the assessment can be found on our local AATC website. And you can see it's under What's New there on the right-hand corner. So I'd like to thank John Sapero and the Office of HIV Prevention at Arizona Department of Health Services for their support. Without their support, this project wouldn't be possible. With that, I'll turn it over to Cesar.
Thank you, Alyssa, and thank you, everybody, for giving us the opportunity to present here today. As Alyssa said, my name is Cesar Igorola, and I'm a clinical coordinator at the Peterson Clinics, which is a multi-specialty or a specialty clinic within the Department of Medicine at the University of Arizona. Our funding comes from Ryan White, but also other sources of funding, such as AATC and then departmental funding. We have a lot of different streams that allow me to be able to do this sort of work without utilizing the Ryan White part of our grants. So with that, we'll jump into our assessment components. So the first part of the assessment is a small introduction about insurance coverage in Pima County, Arizona, regarding PrEP. Then we have some useful terms. With that, we should include that to make it easier to navigate the assessment. We talk about the patient assistance options for Truvada. Also, we review some FFM plans and provide some examples to determine the cost of PrEP coverage. We also touch on Medicaid and Medicare coverage, and as well as private and commercial coverage. And there's some examples, as I said, that estimate the cost of PrEP. So through the guide, you'll see what information you need to know, what information you need to ask your plans when trying to determine what the cost of PrEP for you or for your patient is. We also have some useful resources, and we finish up with an appendix at the end. Okay, so why we came up with this, as Alyssa said, we were approached by the state prevention, and we wanted to have some sort of tool that help people navigate the daunting process of getting into PrEP and coverage through insurance information. Through insurance coverage, I mean, we wanted to create something that people could utilize to make it easier to navigate how to access PrEP. In Arizona, most insurance plans cover PrEP, but the levels of coverage vary from plan to plan. So it was hard to say, you know, it covers and this is what it was covered in Arizona. It varies widely from all the different plans. So that's why we kind of wanted to put together something that would be useful when trying to figure out what exactly your particular plan covers in regards to PrEP. So we wanted to offer a guide on how to navigate health insurance for PrEP coverage. We also provided some examples of how to estimate PrEP costs based on the information that you receive from your respective plans. We review the inclusion requirements for the patient assistance program. So we have the Gilead, the copay card, as well as the Advancing Access. We have the Patient Access Network Foundation, which currently have depleted their funding for HIV care and prevention, but hopefully at some point that will come back. And then we also have the Patient Advocate Foundation. And the report talks in detail on what services they offer and how to go about getting connected with those. And then also we go into detail about what the costs associated with PrEP are. There's three main sources of cost. Lab work is one of them, medication copay, and then clinic or doctor visits copays. Those are the three areas that the PrEP expenses will come from. Please note that the tool is not intended to provide an estimate on PrEP costs for any particular health insurance plan. It was just created as an example. The numbers used in the examples are fictional, and they do not represent the actual coverage of any of the plans mentioned. So in the assessment, we have some examples of how to estimate your PrEP cost. And for example, for the lab work, we said the total cost, or we estimated the total cost of the lab work to be $2,000, which, you know, depending on what health plan you have, that might be the case, but it's just a fictional number we utilize solely for the example creation. Individuals looking for a cost estimate in terms of their own PrEP will need to contact their respective insurance carrier and get details on what their medical deductible is and how much of it they have met, what the drug deductible is, particularly where the Truvada falls in as well, the maximum out-of-pocket, primary care and specialist care copays, as well as lab copays if there are any. Some plans have lab copays, some plans cover it, labs 100% of the cost, but it just depends on your insurance plan. And then also, of course, ask about the Truvada copay. So we wanted to put in a visual, you know, how we come up with the cost for PrEP. So as I said, the three components are the lab costs, medical costs, and then the medication copay. So lab costs it varies from plan to plan. And so once you speak to your plan and ask specifically about your lab coverage, you can get a more accurate definition or estimate of what the cost would be. For example, some plans ask patients to pay 10% of the total. Sorry about that. So some plans ask the patients to pay 10% of the total lab cost as a copay, while other plans ask to pay 20%, and some plans cover it 100%. So again, it just depends on your own plan. The medical costs, that's usually our flat rate, so meaning you will have $25 for a primary care visit and $75 for a specialist visit. And again, those are just examples. That varies from plan to plan. And some plans do have a percentage of the visit as a copay versus a flat rate. So again, all those details you have to check in with your insurance carrier and get those numbers from them. And then the medication copay, depending on what tier the Truvada has been placed in your plan, that's what's going to tell you what the cost is. But other factors to consider is the maximum out-of-pocket cost, which once you meet that number, you don't pay for anything else for your medical services. So say you have a great insurance plan that has a maximum out-of-pocket of $2,000 and you have a Truvada, or you get on PrEP and your Truvada copay is $1,000 every month. By 2 months of filling that script, you will have met your maximum out-of-pocket, so then you won't have to pay anything else for medical services after that for the rest of the year. And then Truvada patient assistance programs can help support the copay for the drug. So if we utilize that example that I just mentioned, the patient wouldn't be paying the $1,000 for the copay because he or she could utilize one of the Truvada patient assistance programs that would cover that copay for those 2 months. And then after that, their care would be without cost for them. The lab copay, we have 4 because it's 4 multiplied by 4 is 4 times that you're going to be monitoring your getting monitoring labs for PrEP. Also, you're going to see your provider 4 times a year, and of course the medication copay, you'll get it every month, so you multiply that one by 12. And this is an example of a HealthNet FFM plan covered here in Pima County. And as you can see, there's the 4 different metal levels. Typically, the higher the metal, so the gold plans have a higher premium, but the benefits are generally better. The bronze plans have the lowest premiums, but the benefits are not as good as a gold plan, as you can see for this example. So in this example, if we have a patient that had a HealthNet Gold plan and wanted to be on PrEP, we can see that the lab cost would be 100% covered. The medication for the Truvada, the copay for the Truvada, would be $50 every month without having to meet any sort of drug deductible. So from day one, the copay for that plan would be $50, $0 for lab costs, and then the medical visit would be either $30 if it's access to a primary care physician, or $60 if it's actually access through a specialist. So for somebody, say that's shopping for a plan and the FFM for next year, and this is the sort of coverage they will have, then the gold plan might be most cost efficient for them because they won't have to pay anything out of pocket for labs, and the copay is relatively small. And if you see the difference between the premium is, about $50 from the bronze to the gold. So the level of coverage you get would be a lot more comprehensive by paying a little bit more every month. So that's one of the considerations to take when kind of reviewing this assessment and how to figure out what the cost for your plan is. Kind of by looking at these numbers and plugging in the numbers for your own plan, you can figure out or you can estimate the cost for your patient's PrEP cost. So how this tool came about, we wanted to have something that would make it easier for somebody trying to navigate PrEP, access to PrEP. So the different levels of PrEP coverage made it hard to estimate PrEP costs in general. So we wanted to create this tool to support somebody trying to get into PrEP and, offer this as a tool so that they can estimate what their costs would be. We gather information from different insurance we gather information about insurance coverage by looking at the plans online or healthcare.gov. We also work with the Pima County ACA Navigators and assisters to come together with this plan. And we also consulted with independent insurance brokers to make sure that we had all the information that we needed. Of course, all the information, as it was said earlier, all of the insurance information and what is covered can change at any given time. So the information presented in this, or the information used in this assessment was accessed last year in December 2015. Around from the 10th to the 15th, we took about a week to gather all the information. And it's based on insurance coverage for the 2016 calendar year. And although all that can change, the way that this assessment was created, we created the variables that are constant. So, you're always going to have a maximum out-of-pocket. You always have a copay for your medical visits and all that stuff. So basically, plugging in the numbers from your coverage after speaking to them into this tables that we created would allow you to get an estimate on the PrEP, even if the information changes all the time. The idea is that we're going to be using live information because the patient interested in accessing PrEP will be contacted their own insurance company at the time they're interested in accessing PrEP. So the information that we obtain from the insurance plans and the information that somebody needs to ask the insurance plans when they're trying to estimate the PrEP cost, well, the plan premium is not, if you're already insured, then that's already set, so there's not much that can change about that. But the medical deductible, the Truvada deductible, medical maximum out-of-pocket, those are all things that you want to ask them what your coverage is. So what is my medical deductible? What's the max medical out-of-pocket? How much of that have I met? What is a Truvada deductible? What is a Truvada cost or copay? Are there costs for lab work? And then what's the cost for a primary visit or for a specialist visit? Once you get all those numbers from your insurance company, you should be able to plug them into the assessment that we did and then get an estimate of the PrEP cost for your patients. So some of the lessons learned over this last year and a half that we've been doing PrEP here at the clinic. So the insurance coverage for PrEP is not uniform across plans. So to receive an accurate estimate, individuals or the providers will need to contact their insurance plan and get those information we mentioned in the last slide. Patient assistance options for lab work and medical visits would increase the number of people on PrEP. What I mean by that is that people that we've had patients that have been on PrEP for a couple of months, and then the lab work and the medical visit is the cost that overweight their risk. So, for somebody who was using condoms 80% of the time and being on PrEP, and he had to pay $75 every 3 months to come see our specialist doctor, and then he had to pay 10% coinsurance for lab work. After being on PrEP for about half a year, he said, well, you know what, it's just unaffordable because the lab work and the medical visit, even though I'm getting the help for the medication, the other two things I have to pay for is I could use my money doing something else with that. It's not as affordable as he thought it would be. So if we had some sort of patient assistance options to support that, I believe that the PrEP number of people on PrEP would increase greatly. As I said, medication assistance options are available to help with the cost of Truvada. We have Gilead has the 2 programs, and then aside from that, the other one is the Patient Advocate Foundation at this time, and hopefully the Patient Access Network Foundation will come back with more funds at a later time. Insurance plans or insurance companies can change their plans, particularly drug coverage, as we touched on before. So at any given time, they can move Truvada from Tier 1 to Tier 2 or 3, making it more expensive. So we'll have to be aware of that and take that into consideration when estimating your PrEP cost. And again, to obtain an accurate PrEP cost, you'll need the information from your insurance company at the time you're interested in accessing PrEP. And lastly, before starting PrEP, people tend to overestimate the cost, which can be perceived as a barrier to PrEP cost. And this can go in both ways. It's both overestimate, so people that are covered with Medicaid, for example, in Arizona we had Medicaid expansion, and all of the Medicaid plans are covering PrEP. So, people that were on those plans were like, well, I can't afford it, it's too expensive. And after they have the initial assessment with us here, and we tell them, about the cost of it, then it's actually a lot more affordable than they thought it would be. And at the same time, the example I used before, people tend to think, oh, PrEP is not going to be that expensive for me, but then once they start on it, they start seeing that the quarterly lab work and visits do add up and can make a difference. But of course, until you are on it, you won't necessarily know how it's going to affect you. Okay.
So, and I think that pretty much wraps it up, and I wanted to just thank Cesar. He's done a tremendous job helping patients access PrEP here in Tucson. And I know that oftentimes, particularly in the beginning, we see that a lot of insurance companies require a prior authorization, so it really requires somebody at the clinic who's willing to go the extra step and follow up on prior auths and make sure that those go through to make sure that the patient's able to access the medication. And I think that's it.
Thank you.
Thank you. We have a couple more poll questions, and they're on the kind of information that would be most helpful to PrEP candidates to include in these type of tools. And you can check multiple kinds of information. And as people are responding, I have a question for you, Cesar. What's your sense of the number of people who would be able to afford PrEP by selecting a plan going through this process? It's a complicated one, and as you mentioned, for some people, paying the premium for a gold or platinum plan is not going to be an option. And on the other hand, the copays or cost sharing is still going to be prohibitive. So kind of out of, from your experience, what's the percentage or what's been your experience in terms of how these kind of tools help PrEP candidates?
Well, I think the tool that we created in particular will probably be useful this open enrollment period, because then people can navigate through the different plans offered through the FFM, which is the federally facilitated marketplace, and they can look at the different plans and different levels of coverage and kind of decide what plan would be the best for them. For example, we talk about, I use the example of the HealthNet Gold plan that offers 100% of the lab work is covered, the Truvada copay is small, and then the medical visit is also, it's a decent price. So if somebody was interested in, switching plans to access PrEP, then I think this tool will be really useful because they will be able to look at different plans and decide what to take. In terms of how useful it is right now, because we're past open enrollment, people that have their insurances have what they have. So there's nothing that we can change around that. The only thing we can do is review the coverage and kind of provide an estimate. But if somebody in the future wants to get a better plan when open enrollment comes, this will be definitely useful. So for us at the clinic, for example, we've had currently have over 70 patients on PrEP. From that, we had a lot more referrals of people that were interested, but then they decided not to start for different factors. I would say probably around 5 to 8 people decided not to start PrEP because of what the cost would be for them in the long run. Other reasons for it were, people weren't understanding about PrEP in general, and they didn't know that they had to take the pill every day, or they have to do the lab work every 3 months and come see the doctor every 3 months. Some people, believed that they could just take the pill whenever they were going to engage in risky behavior, and that there wasn't any sort of monitoring to go with it. So those are other reasons why people have decided not to go on PrEP after they initially think they want to.
Thank you for sharing that. We have another poll, and I think we're gonna close it, and we can come back to these to the responses toward in our discussion period. So it looks like the flowchart is very popular, and the tables in both of the in this and the previous question showing the breakdown of cost is also important. Great. We have one more poll, and we'll hand it over to Todd and Adam after that. I think both David and Cesar commented on the need to use multiple sources of information and verifying them, making sure that they're the most up-to-date, and even then the complexities in having accurate kind of real-time information. And some of the risks of that the information might change after individuals make a decision on what plan to pick. So this is definitely a complex issue. And going directly to the health plans is an important way to get at this information. So we'll come back to these. With that, I think we'll hand it over to Todd and Adam. Take it away. Todd, you might be muted. Give us one quick second.
The conference is no longer in listen-only mode. The conference has been muted.
Todd, could you press star 7 to unmute your phone?
Can you hear me now?
Yes, thank you. Sorry about that.
It's okay. So good afternoon. This is Todd Grove, and I'm the supervisor of the Healthcare Access Unit at the Colorado Department of Public Health and Environment. We're in White Part B. We have an integrated HIV, STD, and hepatitis C care and prevention program. So I'm going to do a little bit of background about our program, but I was asked more by NASDAD to emphasize the work that we are doing to use staff, both internal and external to the Colorado Department of Health, to work steering clients that are at higher risk of HIV infection to PrEP-related services within the state. So we'll talk about the type of people that we use in our health insurance navigation functions, how our prevention workers and disease investigation staff, as well as our funded case management agencies, are now able to assist in potential PrEP candidates. The Colorado is an expansion state, meaning that we did expand Medicaid in 2014. Additionally, legislation within the state now allows us to use some of the funds that were formerly directed to ADAP specifically to pay for biological interventions, including PrEP. We've developed what's called a Public Health Intervention Program, or PHIP for PrEP, and we're really only now rolling out programs to support people who have cost issues with PrEP. Our intention, as we get it rolled out, and I think we've almost gotten there, is to pay for any medication cost that is above and beyond what Gilead and the PEN or Patient Access Foundation will pay, and then also for the cost of PrEP-related medical costs for the insured or the underinsured. Okay, so first I'd like to start off on talking about how our primarily internal staff identified candidates for PrEP. So we've determined that obviously frontline health department staff and community prevention partners are in the most unique position to identify the seronegative individuals at a pivotal moment. So when those clients are most likely most at their highest risk of HIV infection, but they haven't acquired the virus. So our DIS staff, what we call our comprehensive risk reduction and care service providers, as well as our linkage to care staff and our biological intervention coordinator, have been kind of retasked to work specifically for those clients that they determine to be of higher risk for HIV infection, often because they've gotten related STD. Additionally, our integrated care and prevention staff members and our CBOs, community-based organizations and partners, have been transitioned so they have a combination of both HIV care and prevention dollars based that they can put on their contracts and serve both HIV positive as well as high-risk negative clients. So when people or staff are in the field, after they've determined the serostatus of anybody that they've come into contact who's been identified with an STI, they offer a variety of upstream preventions, including biological interventions, which might mean referral to a mental health provider or a substance abuse clinic, obviously a linkage to a medical home if they don't have one, which might be a community health center or other clinic in the community, and also biomedical intervention referrals. So we refer to that as both PrEP and post-exposure prophylaxis if it's indicated. We're hoping to also run a program out within the next year that would help pay for post-exposure prophylaxis if it's indicated. Those clients are also referred to needle exchange
programs that are now spreading throughout Colorado, as well as harm reduction resources if they're in IDUs. So we developed what we call the Healthcare Access Support Plan, and it kind of has 3 tiers. The one on the left refers to contracts that we have with regional aid service organizations located throughout the state of Colorado. We have one contract with the largest aid service organization in the state to be our insurance administrator, and they have offices in 4 out of the 5 major regions within Colorado, and they subcontract with entities in the other and have satellite offices in large medical clinics. We spent a great deal of time and effort making sure that they were very skilled at enrolling clients on insurance through the marketplace and understanding employer-based insurance plans. We have now started this year to put 10% available on their contract of CDC dollars so they can work on navigating clients into insurance on the marketplace or help clients understand their employer-based insurance plans. And they'll be able to work with them at open enrollment or if they should have a special election period. They are skilled enough that they're actually considered official navigators to the state of Colorado Health Benefits Exchange, or the marketplace. Sorry about that. Other PrEP education and support through the HIV testing and prevention contractors is that we're rolling out basic insurance and benefits training in a PrEP-oriented class that we're teaching here at the health department. We'll teach them how to do on-the-spot Medicaid enrollment and referral information, as well as developing healthcare literacy documents that help people that may have never been on insurance understand what deductibles, co-insurance, co-pays, etc. are. Colorado was one of the recipients of CDC funding to do PrEP enrollment, marketing, and assessment through the CDC, and that project will begin later this year. As far as our internal DIS and linkage to care staff, they do PrEP screening and an immediate referral for high-risk people that are identified. They have access to all the information about clinicians that we've established have the ability to meet with people regarding PrEP. We have understood and come to realize that there is a reticence, certainly amongst some providers, to engage in PrEP. So while we try to increase the number of providers that are available within the state, we've understood that we need to probably invest money in specific clinics and pay for FTE for positions where they would work exclusively with PrEP clients in order to get the use of PrEP up significantly in the state to the point where it would begin to bend the curve of infections. Our staff are able to enroll clients directly into Medicaid if they encounter them in the field using tablets that we've provided with them, and then they can turn the individuals that don't qualify for Medicaid over to internal staff within our healthcare access team for potential enrollment, and explaining the benefits enrolling in open enrollment periods or special election periods, also assuring that they get enrolled into plans that have cost share reductions and advanced premium tax credits if they choose to enroll in insurance outside of the open enrollment, once they do reach an open enrollment period. What we have come to realize is a great number of clients that are being referred to us for PrEP have opted not to purchase insurance. They've decided that the cost of the penalty is less than it would be to pay for premiums, and that's kind of a new revelation that we've had to spend some time working on to how to accommodate those individuals who may choose to continue to do so, particularly if they have any sort of history of not paying their taxes. So to become involved in the marketplace at all leads them to believe that they will be suddenly on the IRS radar and need to make payments of large sums of money going forward. So we are starting to look also at everybody's insurance as they're referred to our programs. So we're going to really look at what the patient's insurance looks like. For example, we'll look at how big the plan deductible is, whether the prescription drug copay cards will cover the vast majority of any deductible that the patient may have that might get them through to the point where they had a much amount of copay for a lab or an office visit that would be manageable. We've come to realize that if we ended up paying the full cost of the labs or office visits for somebody that had a very high deductible, we'd end up paying a significant amount money more for that patient than we may have otherwise done if we just paid a fee for service for the PrEP-related services at particular clinics that joined a network. But if a patient's insurance is adequate and if they would have a standard copay of say $25, $50, $100 for the office visit and a decent amount for their labs, then we refer them to one of our agencies in our insurance administration contractor who will arrange for them to be able to send the invoices that receive for those services to the program to pay those copays for those individuals. Again, if they have no insurance or they're underinsured with these enormous costs, we're developing contract relationships with agencies such as Planned Parenthood that have agreed to see on a fee-for-service medical and labs that are set based on the initial visit versus the follow-up visits that come down the line. We've come to determine that figure would be about $1,400 per patient, and hence you can see where it might be a lot less expensive to pay for that than it would be to pay for the full cost of the drugs, the appointments and the labs for that patient. That patient could still use their prescription drug benefit within that insurance and use the Gilead copay and PAN Foundation processes to get the vast majority of those medications paid for, and we do have a system set up where we would pay for the cost of any drug beyond what those two programs could provide. I'm going to now turn over the rest of the presentation to Adam Brisnahan, who's done a lot of the similar guides that we've developed in Colorado around PrEP, and he's going to share some lessons he's learned about developing these guides throughout the ACA implementation period.
Hi there, I'm Adam Brisnahan here at CDPHE, and I'm going to talk about some of the modified tools that we created here. The first one, as you can see now, is a pretty close riff on the Project Inform Getting PrEP document. We trimmed quite a bit of the info out, especially as we're trying to get our PHIP program propped up here and get a better handle on where we're able to refer people to. I just wanted folks to have kind of general information around PrEP, access to all of our reminder systems and websites as well, and our new PrEP navigation number to reach out to if they have any questions regarding what we can do for them in the meantime. You'll see on the back I did a similar flow chart, but I did break it down more on the income level basis because here in Colorado, as the Medicaid expansion state, different people within different income ranges are going to see different levels of assistance. And so I wanted to break it down in a way that showed them where they're specifically at and tried to get them to the answer that was most appropriate for them. So again, this is just something for people to use. We do recommend if anyone is within the realm of marketplace insurance that they do consider where they're at as far as federal poverty level goes and try to coach them into silver level plans that will leave them with less of a cost burden going forward to access their PrEP. So similarly, this PrEP for open enrollment document was something that I created back before this last open enrollment. Again, while we were still trying to prop up and figure out what we were going to do around PrEP, we didn't want clients and people living within the state to lack information. So we tried to get some things put together that would just broadly answer some questions or give people the appropriate questions to ask when they were looking at insurance products, especially in the mindset of trying to access PrEP. And so with some new regulation that went out through many of the states that use state-based exchanges and their state insurance commission to regulate their products, many of the insurers, all the insurers were required to offer a plan within each tier that had a flat copay for drugs regardless of what tier those fell into. So what I did is I just compiled a quick list of what those plans were by going through the insurance rate filings and discovering which plans had those flat copays on the specialty tier. And so to simplify the process, because I can definitely mirror the feedback that the previous presenters gave, that it's very difficult to try and chase down a formulary to keep your drug access information up to date for each of these plans. And so in order to kind of simplify that, since PrEP is really just Truvada at this point in time, I figured it was just useful to show what they would pay specifically for that drug, what the estimated lab costs were, and then the average premium for a 30-year-old non-smoker in Denver, just to get them a better idea of what those costs would be, and also show them that there were plans out there that they would not have an untenable deductible to meet before they were able to access the drug. Because $550 is still kind of a steep price at the pharmacy, but when you apply the Gilead copay assistance and any other assistance, this would make it manageable for someone to access. So we just try to get as much information out as possible without also putting too much information out that we then had to be responsible for going forward. And that's
our presentation. Turning it back over.
Yeah.
Thank you. We have only a few minutes left, about 10 minutes left. So we want to make sure that we get to as many questions as possible, but also, so as we'll do the polls as we answer questions, if that's okay with our presenters, and we'll make sure to send out the slides and share the poll results and resources that our presenters have mentioned already, and addressing some of the questions. So we'll probably invite participants to continue the conversation in writing. We have a pretty good platform for that will serve as a repository for all the documents and help us with the discussion. So with that, I'm going to get us started with a question from Nestor on the Nestor Rocha from DC on prepping clients to contact health plans, and I'll pass it over to Cesar to see how if there's any resources or to talk about the resources that they've created in Arizona. Cesar, you might be muted. If you could press *7 to unmute your phone.
Can you hear me?
Yes, thank you.
Okay, great, thanks. So yes, as the assessment plan that we created was intended primarily for providers so that they can assist their patients or patients interested in PrEP to estimate the cost. The education that we do here at our clinic, it's one-on-one. So when the patients are interested in PrEP, they call, and typically I do an initial pre-assessment before they make it, or before they move forward with the process. In that process, we talk about the insurance piece, and we do kind of one-on-one education on the costs, where the primary costs will come, how to talk to their insurance coverage companies, to determine their coverage. And then I work with them. They are the ones contacting the insurance and doing all the talking, but then if they have any questions or anything like that, they call me back and I'm able to guide them through the process. So for us, the education is done one-on-one as of now. because of the complexity of all the insurance issues, it's hard for us to do like a general guide on how to talk to your company aside from what we created in the assessment. That's kind of like the most general type of information we could put, and with that, somebody who reads the whole assessment hopefully should get a good idea on how to communicate with the insurance companies and estimate their PrEP cost. But aside from that, we don't utilize or we don't have any standardized forms of education for patients. It's all done one-on-one.
Thank you. There is a question about the effect of USPSTF approval for PrEP, and the answer is a little complicated in terms of exactly what the effect of that would be if it's given a grade A or B, like HIV testing, routine HIV testing was given that grade. Then it would become an essential health benefit, and that would be provided at no cost to the patient, and specific populations would be described to assess the risk. But this is a very, very simplified kind of answer, and we can provide more information through our discussion and send some resources on that as well. David, Todd, are there any questions on the chat that stand out to you?
Not that I can see. Nothing seems to be directed at us.
I see another question about the ICD-10 codes to bill for PrEP, which is one of the challenges in both the data analysis for PrEP and that is and at times in terms of submitting claims, that can be a challenge. NASDAQ just put out a coding guide that's available on our website, and I'll send out the link to all participants. And that has a few coding guide options that providers with PrEP clinics have been using.
Can you hear me, Edwin?
Yes.
So I just would iterate that our problem, we've had some problem using ICD-9 codes. We've made a pretty extensive list of ICD-9 codes or ICD-10 codes that we'd be willing to pay for. That said, the clinics we're struggling in that they were usually seeing the patient for more than just PrEP. So billing a code like that to a program was problematic in that it was often built into a larger clinical visit that was not supported by our program. The other concern that they had is if they only did PrEP-related services and found other medical indication, they would feel compelled ethically to treat that condition as well. So I think the ICD-9 code or ICD-10 code billing concept works better in a PrEP-specific clinic where they're not doing much larger services than just that one purpose.
No, absolutely. The kind of contracting that a clinical provider has with the health insurance is going to be part of that challenge of how they bill. I'm going to make a plug for our upcoming webinar series. The following sessions are going to focus, the next one's going to focus on that prevention and care collaboration within HIV programs at health departments. And then we're going to have the next session focus on evaluation, including some of these components, leveraging health systems data to make sure we have the best possible picture of what's going on for clients using PrEP, and also in terms of uptake estimates. And then the last two sessions in the series are going to focus on some of these provider models, and specifically addressing the billing issues. And I think the question that you pointed to in terms of how a provider is able to bill based on their contracts and what other services they're providing is going to be a key element there, especially for community health centers. Thank you, Todd. Well, we are, yes, go ahead.
Just one thing, this is David. If you find our materials helpful, particularly the flowchart and that sort of thing, Project Inform will mail copies for free to anybody asking for them, as well as our wallet cards. So if you send me an email, devans@projectinform.org, I can make sure that you get them.
Well, thank you for that, David, and thank you everyone for participating in our webinar today. We are out of time, and just as we close, I wanna point to the webinar series. You will get more information on registering, and then you will also get some of the resources that we've been working on this particular topic. Thanks again to our presenters. Very, very useful information. As you leave the webinar, you'll get a couple of questions that will help us both kind of tailor the next sessions in the series, and also help us gather information in terms of what to prioritize as we develop new resources. Thanks everyone, and we will be in touch with you with these resources, the slides, and information about how to continue our discussion. Thank you. Thanks everyone.
Thanks. Bye-bye.